from the American Academy of Pediatrics.
The number of ankyloglossia, or tongue-tie procedures, has risen dramatically in the last 2 decades.
A new AAP clinical report urges pediatricians and families to take a team-based approach to diagnosis and treatment.
84% of women who deliver in the United States choose to breastfeed. And that means we've got a lot of people that are looking for services and that there's journeys that people are taking that aren't easy.
Plus, early registration for the National Conference and Exhibition ends in mid-August, so it's time to book your travel.
There are so many families and children throughout the United States, and then also their doctors facing adversity. And so the coming together to show the support, to discuss the science, is just so incredibly critical.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a conversation about tongue tie and why helping families breastfeed takes more than a quick fix.
Something that has caused me a lot of stress and anxiety in the last few months has been feeding my baby. Now, this is nothing new, but Zelda had poor weight gain and fell in weight percentiles, ultimately getting her the diagnosis of having a sucky suck.
Wow, that does sound tough. Feeding issues are such a stressor for new parents, and infant feeding is something I'm always giving anticipatory guidance on. But Joanna, what exactly is a sucky suck?
Well, it took us a while to figure out her suck was not strong. She saw her pediatrician, a lactation consultant, and a pediatric speech therapist. And eventually it was uncovered that she had a tongue tie and maybe lip ties. And knowing she had issues led us to really work on her suck, and we were able to help her climb some weight percentiles.
Ah, that's a relief. Did your pediatrician recommend getting any of those ties clipped?
He was really thoughtful about it. He told me it might not be an issue in a few months, and we decided to just watch her progress together. Honestly, I'm still stressed about it, which is why I'm glad the AAP just put out a new clinical report, Identification and Management of Ankyloglossia and its Effects on Breastfeeding Infants.
Oh, I have so many questions. And here with some answers is Dr. Jennifer or Jenny Thomas. Dr. Thomas is a general pediatrician and specialist in breastfeeding and lactation medicine in Franklin, Wisconsin. She's also the first author on this clinical report. Dr. Thomas, welcome to the show.
Hey, thank you. Thanks for having me. Boy, that scenario sounds very familiar to me.
Yes.
There's a lot of people, a lot of parents going through it right now.
And let's start with the elephant in the room. People have a lot of strong opinions about ankyloglossia. They didn't used to, but it seems like in the last 10 years, it's more and more people getting fired up about this. Why?
There's probably a number of different reasons for it. We have done a really good job of helping people prepare for breastfeeding, and it's 84% of women who deliver in the United States choose to breastfeed. And that means we've got a lot of people that are looking for services and that there's journeys that people are taking that aren't easy. And so they're looking for answers, and this gets to be a very compelling answer, the promise of something that an easy procedure can fix and help kids nurse is pretty exciting. This is surrounding infant feeding. There's a lot of emotion surrounding infant feeding all the time. And so this just adds another layer to it. And there's a lot of pressure on families now, especially through social media, to address tethered oral tissues. And so we're excited to have this clinical report available to new families.
And you know, Jenny, I mentioned I was stressed feeding my baby. I mean, how intertwined is breastfeeding with mental health?
I think parenting in general is attached to mental health. And there are a lot of different ways that mental health can impact your parenting journey. And certainly sleep deprivation and uncertainty and just sort of the lack of a tribe sometimes, where we don't have the integrated family systems that we need to support new families. And so it gets to be a lot. And if somebody is handing you an answer that looks compelling and easy, there's a draw there to help people out.
So this medium is limited by the lack of visuals, but is there a way that you can help us understand the different types of ties we might be looking out for in the office?
So we're looking mostly for tongue tie. We can talk about lip tie a little bit, but tongue tie there's no really good universal description of what a tongue tie is. And so it is a restriction of the tongue that makes range of motion a little limited. And in breastfeeding, the latch involves the baby's tongue extending and elevating. And if the tongue does not elevate symmetrically, we can get impacted milk transfer, and we can get pain with breastfeeding. And pain with breastfeeding is an important reason that people quit breastfeeding. And so being able to fix the latch is just the important first 8 out of the 9 steps that you take. You just fix the latch, fix the latch, fix the latch. But tongue extension and elevation is necessary. And so if the tongue doesn't extend and elevate, then we might have a tongue tie.
And to follow up on that, I see a variety of grading systems. I hear you mentioned lip ties, posterior tongue ties. Is there something I should be looking for specifically out of all this?
So right now, there is no scoring system that's been validated or has been found to be reliable. And that's an important piece of information because people use all sorts of different scoring, and it's not reliable, it's not valid. And so those tools are not as helpful as they need to be. That said, the breastfeeding experience is a dyad. It's a mom and a baby. And so the scoring charts that focus just on the baby are really not taking into consideration how that mom and baby work together. And so we've seen that with the explosion in the amount of information about tongue ties that are available, that a lot of the focus is on the baby when it really needs to be on the breastfeeding mom and baby dyad.
But Jenny, I don't want to ignore these so-called lip ties and posterior tongue ties. How did those become part of this whole conversation?
When these procedures were starting to be done in a lot of different places, there was sort of an explanation as if the lingual frenulum was a separate structure. And then there was some work done anatomically that shows that it is not a separate structure. It is the attachment of the fascia of the floor of the mouth. And so that fascia is oriented laterally and attaches to the ventral surface of the tongue. And so it's not actually set up in an anterior-posterior direction. The posterior tongue tie, it's hard. There's not a really good definition of what tongue tie is, and then really not a good definition of what posterior tongue tie is. And I think that it's used very frequently to indicate that it's not a tie that extends to the tip of the tongue. So anything that's a little bit farther back, an attachment that's a little bit farther back, gets to be described as posterior. But again, we don't have any validated or reliable scoring system, so it's really sort of difficult to give any answer that makes a lot of sense in terms of what a posterior tongue tie is. The lip tie is a completely different story because we don't have a really good idea of what the lip is supposed to do with the latch. And people will talk about how the lips need to flange, and there's no evidence that the lips need to do that. The lip needs to be able to create a seal, but it doesn't need to have like a crazy range of motion. And I've personally latched kids who've had a cleft lip, and as long as we can create a seal, that's fine. But there isn't any appearance of the lip that makes it tied. And the scoring systems for lip tie are even worse. And so there isn't a biological plausibility that it will be a problem. And it also, most of the studies that look at lip tie do it in concert with a tongue release. So there are very few studies that actually look at just the release of the lip. And so right now we're not recommending that there's any procedure that's done on the lip. And we don't really have any reason to do it from a breastfeeding perspective. There may be some issues with like cavities in the teeth, but that wasn't what our paper was about. We're looking for breastfeeding reasons for lip tie, and we didn't find any.
And knowing this and the difficulty in defining what these ties are, what should general pediatricians be doing in their offices to assess for ankyloglossia, and should they be making referrals to help them?
So I think for a general pediatrician, the team that wrote this paper, what we want is to make sure that the general pediatrician knows how very desperately moms want to breastfeed and how much help they need with that journey. And we very strongly feel like the investigation of breastfeeding problems or feeding problems needs to be done within the medical home. And so your families are asking you to be good supporters of breastfeeding. What I have started to do now in my own practice is to say, I am checking for ties, because that is one of the first things that happens on social media. Somebody says he's too gassy or he's spitting up, and there will be a comment that says, has he been checked for ties? And so I use that exact language. I am now checking for ties. And then talking about pain and looking at growth and milk transfer and all of the things that go into a good feeding history need to be taken care of. And if you don't feel like you're seeing like a shortened lingual frenulum, we can still talk to speech therapists and lactation consultants. We really think that there is a team approach that needs to happen where everybody's skill set is valued and to work for the betterment of the families. I think what we're seeing is that the parents and the families of these breastfed babies are like caught in the crossfire between some really, really strong opinions about what should be done. But what we need to do is breastfeeding support in a team through the medical home. And that's what we're recommending.
And I think I know the answer to this question, but is there any groundbreaking study everyone should be referencing on diagnosing and treating this?
Our paper. Otherwise, no, it's a frustrating literature base to work in, because there are oftentimes more than one variable that are being investigated, more than one outcome that's being investigated. The randomized control trials, even the control group got the procedure. And so there isn't really, like, it's nice. Nikki Mills' work on the MRIs of the latch, those are pretty cool to take a look at. But in terms of like, this is what you should do, the literature is really, there's a lot of problems with it.
Okay, I wanted to leave this conversation feeling confident about what to do with ankyloglossia, but honestly, I'm still a little confused. When should a baby get a frenotomy, and when will they just get better at feeding on their own?
So we would recommend a frenotomy if there was a complete feeding assessment done and there was maternal pain that was unrelieved through different position changes. We would recommend that if everything else being equal, if that tongue movement is the reason that the mom has pain, or potentially that the baby's tongue doesn't extend or elevate, and that could be a reason for poor milk transfer, we would recommend a frenotomy. We are recommending that the families go to a provider that will bill their insurance instead of charging cash. There is no compelling reason for it to be done by laser. And usually the laser providers are asking for cash. We have a lot of disparities in breastfeeding advocacy and promotion and access to care. And if this is a procedure that the baby needs, we would like every baby to have equal access to the procedure. And we can't do that if some of the providers of this procedure are not making it cost effective for families to go through. So that means creating a team potentially with an ear, nose, and throat doctor. I do these procedures in my office because they're really not hard to do. So if one of my patient needs it, I can do it, especially like brand newborns.
So, Jenny, if you're not an expert in breastfeeding support and you don't have time in your practice to properly address breastfeeding management issues, where can you go for help? Does the AAP have many educational resources, or should we partner with community members?
I think we need to create a team around the family that can be a speech therapist. You should have a lactation consultant in your community or in your practice that you trust to do a good assessment. If there are dentists that are willing to make this a cost-effective procedure, they can be very helpful. But creating a team around infant feeding is important. We have a lot of resources through this section on breastfeeding. We have the physician's handbook for breastfeeding. We have a residency curriculum. We have papers on how to create a breastfeeding-friendly office practice. And our 2022 policy statement on breastfeeding and the use of human milk has a really wonderful technical report that can share with you different ideas. But it's pretty clear that we need to have a good idea of what's happening in our communities, and we should be able to have a team of people that are ready to help with infant feeding.
So, Dr. Thomas, is there a way for us to predict which babies are going to improve with supportive care and lactation support, as opposed to those that we might want to refer to get a procedure?
Yeah, that's a great question, because we've been asked several times about what the timing of the releases would be. There's a lot of nipple pain in the first 7 to 10 days that needs to be worked out in terms of getting latching better. There are feeding difficulties that happen in the newborn period from things like medications in the epidural that can affect the way that the babies learn how to transfer milk. We've really sort of stayed away from trying to put a time limit on this. And it's a combination of physical exam and the comfort level of the team surrounding that family with how well that baby is latching and like sort of narrowing down. Is everything else been maximized and the baby is still not transferring milk well? I think those are the babies that need an intervention, but trying to predict which ones are going to get better on their own, that's harder. We did get asked by a number of different reviewing groups to give a time limit, and we just did not see that's helpful. Like a kid who's got a distal attachment, like the frenulum is right at the tip of the tongue and the tongue is heart-shaped. We don't think that there's any reason to wait on those because it's pretty clear that the baby's tongue is not going to extend or elevate. And it gets a little trickier when the insertion for the frenulum is not right at the tip of the tongue. And that just means getting a good team around the family and finding out if we can improve things. And if we sort of run into a roadblock, then doing that procedure.
And Jenny, if you decide that this is a procedure that the baby you're caring for needs, what are the risks of the procedure that you should warn families about?
Well, in general, it's a really not difficult procedure because I know how to do it. And it also doesn't take very much time to do. The risks are very specifically oral aversion. So we have seen with laser releases that burnt tissue can cause the babies to not want to eat. Some of the dentists will take care of the superior labial frenulum, the inferior labial frenulum, and take rid of buccal ties, and sometimes doing all of those at once. They also are recommending that you go in and break up any forming scar tissue so the wound can heal by secondary intention. And I think we're starting to see the literature break out and say that the aversion is happening because of the lasers or the amount of procedures done at one time. And certainly the post-operative manipulation of the wound can be problematic. So the procedure itself is not difficult. But if there are multiple procedures that are done at the same time, or we are doing this repeated painful stimuli to the mouth, we're starting to see complications from that.
Jenny, this has been so helpful. Before we let you go, do you have one last takeaway for the pediatricians who want to support breastfeeding dyads in their clinic?
I love the idea that that pediatricians are going to support breastfeeding. I think the biggest wake-up call for general pediatricians is that families are willing to do an awful lot to make this successful. And we need to be the point in the community where families come in and feel like they can have their choices supported. And that my big thing about this whole thing is that families are desperate for our help and we need to meet that need.
Dr. Jenny Thomas, thank you so much for joining us today.
Thank you for having me talk about this.
To read the clinical report, Identification and Management of Ankyloglossia and its Effects on Breastfeeding Infants, go to our website at aap.org/podcast.
Coming up, we'll look at what we can expect from the 2024 National Conference and Exhibition. I am always excited for the National Conference and Exhibition. I started to go in earnest during COVID when the conference was all virtual, and having it back in person has been a joy.
And this year, the in-person National Conference and Exhibition runs from September 27th to October 1st in Orlando, and it's important for so many reasons. Pediatricians are facing critical issues around child health, whether that's obesity and nutrition, new viral threats, the mental health crisis, or basic access to care.
Right. And the national conference is a great place to learn from real experts in the field on all of these topics, as well as to network and meet so many of our colleagues from all over the country.
One thing I'm thrilled about is Dr. Elizabeth Murray, a pediatric emergency room doctor, an old friend of mine, and a fierce advocate for children. She is also now the incoming chair for the National Conference and Exhibition. Dr. Murray, welcome to the show.
Glad to be back, and I'm so excited to talk about this really fun, awesome topic. I love the National Conference, and I'm excited to be part of it.
And I'm not sure our listeners know exactly what the conference chair and the National Planning Committee do for the National Conference and Exhibition. Is this a position all AAP members should be thinking about applying for in the future?
We would love it. We would love it. It is a committee, kind of about 25-ish people. And then I have to say, though, there is AAP staff assigned to it, and they are awesome. They will never, ever, ever toot their own horns or acknowledge that they even exist. But my great thanks to the AAP staff, Katie Freeman, Jerry Cohen, and their team, who help us as well. They are awesome. But we try to have the planning group be a kind of representative mix of people from throughout the country, different ages, different specialties, different levels of time in their field, so we can get a good mix, because we want to make sure that we're really representing our audience and bringing together a great package for our attendees.
And Elizabeth, as chair, what are you hoping attendees will take away from the conference? Do you have your own personal mission statement in your head?
I sincerely hope that, now more than ever, this concept of coming together in unity and support is so critically important. Coming out of the pandemic and being able to be back together in person was wonderful, but now there are so many families and children throughout the United States, and then also their doctors, facing adversity. And so the coming together to show the support, to discuss the science is just so incredibly critical. And so I want that rejuvenation that we all feel about when we're together with our friends, when we see somebody that maybe we trained with 10 years ago and we happen to run into them in the hallway, and that coming together, and that the reminder of our great purpose, the health and safety and welfare of children and their families.
And knowing that it's so important for us to come together and there are these adversities we're facing as a profession, how did the planning group approach the conference this year? What topics did you prioritize in terms of education?
We really wanted to make sure that we were focusing on a breadth of topics. We have kind of what we consider core things that you will see at every year or every other year, because we know that bread and butter pediatric educational knowledge needs to be there. But we wanted to also kind of expand the special experiences for our attendees. We always have the Community Cares Project that's going to be expanded to 2 days of a different event. We are teaming with a group called Social Offset, which is an organization that supports vetted charities in the location of your choice. So we chose charities in the Orlando area that work to improve the health and safety of children, their families, the environment, things that align with the goals and the missions of the American Academy of Pediatrics. So our members can then further partner with the Social Offset group to bring funds, to bring awareness to charities in the area that we know are vetted, responsible organizations that, again, align with our values. Over the years, if you think back before pandemic, the conference looked different, and any organization, any conference, any meeting is going to need to evolve and adjust over time. And we've been through so much in the past 5 or 6 years. And so to me, it makes perfect sense that our conference is continuing to evolve and change. The outline of the days, the timing of the events we structure, what we do as a community in the location that we're attending, but as we do as a community together as pediatricians. We want to stay fresh. We don't want to just do it because that's how we've always done it. And I think that the group has really taken a long look at making sure that we are bringing some science with us to the community. And I think it's going to still be a really great event.
Do you have any highlights you recommend that I should add to my conference planner now so I'm sure not to miss them?
Well, the good news is that a lot of our really popular events do repeat throughout the conference. There's opportunities for about 74 hours of CME, which is amazing, which turns out is far more than anybody needs for almost any state licensure per year. So that is great. We have 70 different councils and sections going to have their own meetings as well, the president's reception. The plenary, you asked before about what does the chair do? Well, I'm the person, if you don't know me, I'm the person who's going to stand up and introduce introduce the whole conference at the beginning of the opening ceremonies of the plenary sessions. I think that you can find your people when you're there, whether it's officially a section or a council or people that you've trained with in the past, have the opportunity to be together with your friends, go out to dinner, grab a coffee, enjoy the various educational experiences. I think there's a lot of great stuff, and we cover 70 different topics in general too. So never a dull moment. And like I mentioned, some will repeat, and then there is the virtual option. So there's going to be educational experiences that will continue out through January that people can take advantage of too. So something for everybody.
And for everybody who's coming, they want it to be educational and engaging, but they also want it to be a safe environment for them to learn. So what is the AAP doing to ensure that pediatricians who come in person are going to feel safe and supported while they're there in Florida?
Safety of our attendees has always been a priority. We, for many, many years now, have had various types of protesters attend our events, and we have been very impressed with and very supported by the groups in Orlando, the police there, the facility, security, and staff. The layouts of the convention center and then our primary hotel are such that it provides kind of a barrier so that any protesters we expect to be far away. The police are very cooperative and understanding that the safety of our attendees is critically important. It is our facility while we are there, so we can set up the bathrooms however we want to set up the bathrooms, and we will have all of our activities for the most part within either the convention center or that primary hotel, so people will not have to be walking great distances to different locations throughout the area. All the educational experiences are going to be pretty close together in one spot.
Elizabeth, our colleagues in Florida and in many other states are facing some real challenges in terms of the political and legal environment they practice in, with real impacts to the children and families they serve. What does the fact that the AAP is meeting in Florida right now mean to the pediatricians who are practicing there?
I cannot exactly speak for the pediatricians living in those communities. I have the luxury of being in New York State, but I will never, ever forget the statements I've heard at the leadership conference and other places from pediatricians in Alabama, Tennessee, Florida, saying, don't leave us behind. We need you here by our side to show the strength in our community, to share the science with those who've been given disinformation. We want you here with us. And, for me, I initially was very concerned about the concept of where are we going to be holding these conferences? What do we need to do? But it was upon hearing these really heartfelt requests from those who are actually on the ground saying, please come be here with us, that I immediately said, all right, that's it. That's what I want to do. That's what I need to do myself. It's felt like the right decision, because if they would like us there to show strength and solidarity with them, then we will be there by their side.
Elizabeth, where can pediatricians register to attend the conference?
I think the easiest way, just Google AAP experience and the website will come right up there for you. And you have all the information about the conference, not just registration information.
And what's the deadline to register?
Well, the early bird deadline is August 16th, so might want to jump on soon.
And you mentioned virtual options for attending the conference. What does that look like for 2024?
So there will be an option to experience a lot, not all, but a lot of the conference virtually. And again, there will be, for the all-inclusive package too, you can watch things all the way through January. So plenty of time to get your CMEs. And also new this year, we do have a one-day attendance option too.
Well, I'm excited to be there, and I am ready to roll up my sleeves and support our colleagues in Florida and across the country. You are all doing amazing work. Elizabeth, do you have any last thoughts about the conference and all it's going to offer?
I'm really excited for it. I think we have a great opportunity to bring the science that we know to be true, to come together with our colleagues, to be reinvigorated, to remind ourselves why we love this career that we've worked so hard to succeed in and to help families and children. So it's one of my favorite times of the year. I'm excited to see everybody in person. I've heard rumors that there's going to be puppies one day at the exhibition hall. So come for the puppies. There's going to be a lot of great events. But again, there's going to be that community, that togetherness, the educational experiences. But we're all going to be together because we know it's the right thing to do. And we love our jobs, and we enjoy the patients we care for and the families that we help. So we'll come together and share that great knowledge with each other.
Dr. Elizabeth Murray, it's so great to have you back on the show. For anyone wanting to see or hear more from Dr. Murray, come to the National Conference and Exhibition and re-listen to episode 62 of the podcast, where we talked about medication safety. Dr. Murray, thanks for joining us today.
My pleasure. Thank you so much.
For more podcast episodes, including recaps of the National Conference and Exhibition from years past, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, I'm so excited because our middle child, Sellers, has not been home all summer. He's been working as newspaper editor for his college. And so we're going to go up and see him and really enjoy Boston and spend a little chill time with him and have some meals. And I don't even know, probably run along the Charles River and just enjoy his company. He's good company.
Oh, that sounds so fun. My Say Ah is also a little bit about family. I have a lot of family that actually lives in Seattle, David. I don't know if we've ever talked about this.
Oh, no.
And we're going out to visit this August. And while we're not there yet, I've been chatting a lot with my family there. And it includes a cousin who I consider to be like a brother to me. And we just haven't seen each other since pre-COVID. So I'm sure there's going to be another Say Ah about the trip itself. But even just that ability to connect and the fact that we're going to bring the whole family to the West Coast is something we're all really excited about in this house. A lot of FaceTiming.
Awesome. I know you love it out there, so I cannot wait to hear all of the ahs you're going to say when you get back. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll have the August edition of First Up.
We'll also talk about oral health care for children with developmental disabilities. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.